Hello and welcome to Checking the Vitals, a podcast powered by Specialty Care. I'm Todd Schlosser, and joining me today is Dr. Leon Eydelman, an emergency medicine and intensive care unit physician. In this conversation, we discuss why he decided to focus on emergency medicine, and we also discuss his focus on ECMO and his experiences with setting up ECMO programs. Enjoy the conversation. So, Leon, thank you so much for joining us here on Checking the Vitals. I appreciate your very valuable time. But I'd like to start off by asking, what was it that initially drew you to want to work in the healthcare space in general? Not necessarily surgeon, not necessarily your specialty, but in general.
I've had to answer that question a lot of times in the last 20 years, and I never really have a good response to it. For as long as I can remember, I've been pretty lucky with this perspective. I've wanted to be a physician and be in medicine. I don't really think I knew kind of what that meant or what that would entail on a day-to-day basis, but really, and I remember playing with, friends of mine with action figures and stuff, and I'm always trying to be the medic, So
Yeah.
this, for whatever reason, was something I never had to think about, as far as I know, and just was, which, it's a tough origin story, I guess, but it's cheap. It worked well for me. I never really questioned or wondered, and I've been trying to do this since, end of high school, really.
Yeah, no, I'd imagine that, obviously, it's one of those careers that you sort of, as a kid, like, I want to be a doctor, I want to be a lawyer, I want to be a fireman, those kind of things.
Yeah.
And that's sort of like what it sounds like for you. And you just sort of stuck with medicine, whatever that came out to be. Eventually we'll talk about what yours manifested as, but a lot of kids are just like, I want to do this. It's rare that someone continues with it their whole life. So that's pretty awesome. And it said and you said that started sort of coming out the end of your senior year of high school as you were, I'd imagine, prepping for, your undergrad, where did you end up going for your undergrad?
I went to the University of Illinois in Urbana-Champaign with about a third of my graduating high school class, and that was pretty much autopilot as well. I majored in economics, liberal arts economics. Yeah, so which was a major that really it doesn't exist there anymore because it's a bit of a nothing burger major. Not to put it down anyway. I learned a lot. I just it allowed me to take all of my pre-med requisites. Because it was part of the liberal arts and sciences college. So it fit in and made it easy. I enjoyed it. And so, that was what I majored in there, with the understanding that whatever job someone can get in it, that was not going to be what I was trying to do with it.
Well, I'd imagine that if you were thinking about medicine your whole life up till this point, you weren't thinking about taking a job in economics, which would take a lot more schooling than just that one degree. I mean, to go into an economic career path too.
Yeah.
So I'd imagine at some point towards the end of your, undergrad collegiate life, you were sort of focusing on taking the MCATs and, where you were going to go to school. So where did you end up going to med school?
I went to medical school at Rush University Medical College in Chicago. And I grew up in the suburbs outside of Chicago. So that was where I went to school. Was there for 4 years at Rush.
Yeah. So when did you decide on the specialty that you set on for your medical career? Because you have to decide that before you go into residencies, right? So when did you decide? How did you come to that decision?
So I was lucky again. I was very lucky, my whole life story pretty much. But that as I was finishing up with medical school, there was a lot of noise about emergency medicine physicians starting to get to go into critical care. And as luck would have it, the best rotations I had at the very start of my fourth year, I knew I wanted to be involved in something that was high stakes at times. Something from a time sensitive perspective, there's a need to kind of perform well and try to perform at your best and really kind of hone that skill set as opposed to maybe more of a clinic-based skill set or even a knowledge-based skill set. I was a little more interested in the team-based and the performative kind of skill set. So I loved my emergency medicine rotation at Cook County. I loved my first critical care rotation also at Cook County. And then lo and behold, I could do them both. So that was kind of my plan applying to residency again, was, I'll do this emergency medicine residency, but most likely I'm going to go to critical care and maybe some combination of the two, but that, I was definitely going to get fellowship trained as well.
Yeah. Well, and it seems like, and I realize that residency is a sort of a match program. You sort of interview a lot of different programs, and they of course interview you as well. And then you like behind the scenes say, I want to go here. And they say, we want these people. And then you end up where you end up. Right. And you happen to end up out in Vegas, it seems,
Yes.
At the University of Nevada. So I'd imagine that was one of your top choices. And there are some draws to Vegas, but what do you think, drew you to want to go to that program specifically? Not necessarily the town, but the program specifically.
Yeah. I really, part of it was I'd never really left Illinois for long at all. I mean, I grew up in the suburbs. Like I said, I went to college at U of I, went to med school at Rush. So when I went out there to interview, I was in love with the desert. I was in love with the terrain and the people I really, really enjoyed meeting. So I ended up ranking, in my top 5, a few programs out west, a few programs in Chicago, and the chips kind of landed where they did. And I was thrilled to get to go to Vegas. The town is a lot of fun too, but the other thing about Las Vegas, now it's changed a bit, but especially several years ago, there really wasn't much. There aren't any big university centers. There really aren't a lot of fellowships. There aren't. So when you're the emergency medicine team at one of these hospitals, that's it. There's very little, if anything, that isn't something you can do, because there aren't these super specializations, versus where I went to fellowship then at Emory, exact opposite. There's these highly specialized teams of people with a fellow and a super fellow and people that have been training for 10 years and still aren't done training. And so then, emergency medicine from that perspective takes a different tone, where you're not going to do these things on your own, because there's people more skilled and they're right upstairs. So,
yeah. So do you think, and this is just my speculation, so please correct me if I'm wrong, but while you were in Vegas at the University of Nevada and your emergency medical residency, that because you were one of the few out there, that you got much more practice, much more hands-on maybe is the better term, with emergency medicine than you did when you went to Atlanta. I think that's where Emory is, right?
Yes,
in Atlanta?
Yeah, exactly right. Yep.
So is that a fair statement?
That's a very fair statement. I think the things we saw in Atlanta, they, sometimes the emergency department would consult dermatology, which was not, I didn't know. I said, what? You can do that? I didn't even know you didn't have a derm residency. And so it's one thing to call an attending who, it's just a much different perspective. They're not going to come in and do something, and they're probably not that interested in talking to you at night anyway, versus you're in a place with a residency fellowship. Well, there's a resident awake, there's people there, their job is to do that stuff. So
yeah,
definitely a different tone. I think, on the one hand, you got to do more stuff in Vegas. On the other hand, you got to learn from people that had a lot more experience doing it in Atlanta.
I'd imagine that at Emory, just to jump into that, that there was a lot more collaboration between residency programs because, like you said, they were there, they were available, they're the experts in that specific thing. And with emergency medicine, and again, speculation, so correct me if I'm wrong, you are seeing a plethora of sort of everything on some level, because it's gotten to a point where it's an emergency, and that's why they've come into the ER. But that could be anything from a broken arm to, seizure, stroke. It could be anything where you might need to engage someone who is, a neurosurgeon or, a dermatologist, like you said, or someone who's more specialized in that. So I'd imagine that you are able to learn a lot more about other subspecialties in your sort of emergency medicine residency than you would if you were like focused on the one neurosurgery. You may not get as good at neurosurgery as them, but you probably have a very good baseline knowledge for sort of all the specializations out there.
Yes, that is what we say, and that's what we believe. Although if you ask each of the specialties, they probably might be saying, yes, that's the ethos of emergency medicine. It's absolutely true. Because if nothing else, you need to have someone who knows what's going on enough to figure out when it's important, when it's not, and who needs to be notified, if nothing else. So, and typically emergency medicine does much more than that, but that's if nothing else, you have to know something about all of those. So, and that really was, when you're at a place with more specialties and more things and more options come available to you, and you can learn about when they need to be deployed, and really extracorporeal support is not something we really did in Vegas. And so before I got to fellowship, to me, it was like, reading about, watching videos about, and thinking, wow, this like magic device. It definitely was a big shift when I got to Emory, and that's very much just a common thing. And that's just what they do at these high level centers. Yeah.
So I know that, and I think you went your fellowship around 2016, right? And then it was 2016 to 2018. And I know with a lot of other subspecialties, you have a focus for your fellowship? Residencies like emergency medicine might have been your residency, but your fellowship may have been a fellowship on something. Did you focus on anything in particular during that fellowship time period?
Yeah, my fellowship was in critical care. So these are kind of fellowships that have board certifications, have kind of specific vocabulary, I guess. So critical care is my subspecialty. That's something emergency medicine was allowed to go into in 2013 through, I actually did it through anesthesiology. Most emergency medicine folks do it through internal medicine. So there's a variety of governing bodies who make their deals and shake their hands and figure out kind of how to get it done. But so my paperwork says, I'm co-boarded by the Board of Emergency Medicine and the Board of Anesthesiology in critical care after my emergency medicine board. Right. So that was kind of my fellowship focus. And then, for critical care fellowship, it's 2 years for emergency medicine graduates. It's 1 year for anesthesia graduates because their residency is a year longer. So with the second year, it gave me the opportunity to really focus on something else. And that focus for me was ECMO and extracorporeal support. So that was kind of, sometimes I tell people that was my minor.
And that's sort of fortuitous because ECMO was a thing then, but ECMO really got ramped up in the past year, 13, 14 months at this point because of COVID. And I'd imagine that in emergency medicine, you saw a lot of it. You guys are on the front lines of that sort of wave as it was coming through. Although I'm not quite sure where you ended up post-residency. Did you go back to Chicago?
Yeah, so post-residency went to fellowship in Atlanta. I was there for a couple of years, and after that, came back to Chicago and started working at Advocate Aurora, so at several different hospitals, initially mostly at a big site called Christ, which has a big emergency medicine residency. So, at that point, doing about 10, 20% emergency medicine, the rest all critical care. So working in the intensive care unit for the most part. And then when COVID happened, I kind of had to abandon my emergency medicine shifts because things just got so busy up in COVID land in the ICUs. And so, man, that was something else to see and something I hope never be a part of again. But you're right.
I'm sure everyone shares that sentiment. Yeah,
right. It did kind of put ECMO on, much more of a layperson map. I mean, there were bursts of this during H1N1. There was some kind of lay press about it, and then every now and then, there's a great save on like a frontline soldier, someone who had a blast injury, and you see a news article about extracorporeal support. But you're absolutely right. The last year, as so many things are now kind of common discussions. I'm talking about ventilators with my friends that are not in medicine. I'm talking about ECMO with my friends that are not in medicine now, which is an interesting change.
Yeah, and it's fortuitous that was sort of your specialty in your fellowship. You got very good at ECMO, so I'd imagine that you were the go-to ECMO guy at all the places you service or all the places you make rounds. And I'd like to talk a little bit about that if that's all right. So I believe, and correct me if I'm wrong, you started a ECMO program where you ended up. Is that the case?
So so we're initially I did bulk of my time at Christ, and that's a very large cardiovascular surgical center with an excellent CD surgery team. And when the pandemic really hit hard in Chicago, they really kind of pivoted away from doing a lot of cardiovascular cases to being much more involved in extracorporeal support for our lung failure patients. And so my group, my intensive care unit group, is all people roughly my same age and disposition. Let's say many of us are emergency medicine, and so I think we think pretty similarly. So we were thrilled to be able to now have folks who'll be putting these people on ECMO for us. We weren't quite as involved in the day-to-day management. I think the surgeons do a great job and they run a tight ship in their own unit. So, so was very involved at the beginnings of that and helping out any way we could and learning as much as we could. We then were brought over to a different hospital as well as my group expanded to a different, pretty large tertiary care hospital that didn't really have much of an infrastructure for extracorporeal support. And there, myself and a few partners of mine and my group as a whole kind of took the lead in helping to set up more of a systematic program to keep our VV, in particular ECMO patients there, to grow that kind of product and to keep them in the medical ICU, which is a little different than most places do this. Most places will keep their ECMO patients in the surgical unit because that's where the hearts would go. That's, typically those nurses have more experience with that. Our group is a little different. We're very much kind of medical ICU people, but we're a 24/7 physician staffed intensive care unit. So that made it much more feasible for us to really obviously be there 24 hours and to help set up a program that we thought was safe enough yet kind of dynamic enough and novel enough that we could achieve the goals that we wanted.
I'd imagine that is the difficulty, or one of the difficulties maybe, in setting up an ECMO program at, specific locations, because they already have pre-existing policies and procedures, and you want to make sure that ECMO program, however it is birthed or however it is formed, fits in within that key network, within those policies and procedures. So, whereas some people have them in the surgical wing, you guys do it in the medical wing, and it's just because of how you guys were already pre-existing. So having that experience of sort of setting up, or at least sounds like helping set up ECMO programs at these locations, what are some of like the key learnings or key takeaways that you discovered or came across when helping people set up these ECMO programs?
I think there's a lot of confusion, maybe not confusion, but a lot of uncertainty about kind of scope and what we ought to do, what we can do with our ECMO devices and ECMO patients. And I think that's, it runs a gamut from some folks I immediately say, oh, that's just, a way to keep dead people dead, but warm for a few more hours. Like, what are you guys thinking? Versus other folks are like, oh, I saw that in the news. That's going to save everybody. And so I think because it's not quite that frequently seen and isn't quite so kind of general in the house of medicine, I think that was one interesting thing we ran into, was kind of managing and then developing expectations of what are we trying to achieve? What would be successful for us? And then from that kind of less medically, but administratively, was my first foray into trying to build something. And you mentioned the policies and procedures. There sure are a lot of policies and procedures in the hospital.
And they vary. I mean, I've noticed this just having gone, and actually we used to do this podcast in person, and I would go there and set up cameras and stuff. And some hospitals, to even enter the hospital, I would have to sign like a bunch of documentation about specifically what I'm allowed to do with cameras in the hospital. And I'm not there touching patient care at all. So I can only imagine what that is like for someone who's going in to start something that actually would be patient care.
Yeah. And so I think, the people that know the most about this by definition pretty much always are perfusionists. And so we had the privilege of working with, with specialty care perfusion group, and they were a really good bridge for us, because they knew all the cardiovascular folks. They knew the surgeons who aren't necessarily that interested in honestly dealing with whatever complications we end up giving them. Right. I mean, they're not that interested in ARDS management. It's not their ball of wax. They're surgeons. They like doing complicated surgery. So perfusion was already in the know. They knew those people, and they kind of controlled, with us at least, they controlled inventory. And so that made it so much simpler to develop a relationship with them, with my colleagues there, and kind of start that from the perfusion/intensive care physician perspective. Because once we had those two pieces, we had medical responsibility, as it were, someone who's willing to say, yeah, I'm here, like I will respond immediately. We'll figure this out. We'll approach these patients 24/7. And then I have a perfusion team that's willing to do that as well. Then the next step was education for nursing staff. And with those other two pieces, it really fell into place with developing a pretty robust kind of initial curriculum, and then a whole bunch of checkpoints and simulation sessions with our nursing staff to get them up to speed as well.
Yeah, it sounds like you're sort of touching on my next question, because a lot of locations, a lot of hospitals handled this differently, but during COVID, the demand for ECMO sort of spiked, so much so that perfusionists could no longer handle it all. So how did you crack that nut of how do we have everyone on ECMO who needs ECMO, and sort of allow for patient care to be as high as possible, but realizing that a perfusionist can't touch all of those cases just because there simply are not enough of them?
Yeah, and also the reality is there is a need for someone who's highly trained. Not that nurses and doctors aren't highly trained, but there just isn't. You don't need someone with that specialized of a skill set to be sitting. I don't think you need someone with that specialized of a skill set to be sitting 24/7 with VV ECMO patients if there isn't something going on that they're needed for. And
Sure.
I think because we have physicians at bedside 24/7, made it so much easier to say, look, if we need you guys, we'll be calling you at 2 a.m. We're already there. We're up. We're awake. we're there. So that took a lot of the edge off, and I think was a good way to bridge that for us, to just kind of, I put that on the backs of my colleagues then, to say, hey, like, perfusion won't be sitting. They don't have to, they don't want to, and they need to be fresh for surgeries in the morning. It's just not effective any other way. So a lot of the burden then fell on our nurses, and they really, I mean, they approached it with such a kind of professional air. They were very excited to do it and to start learning things and doing things that they weren't doing before, and especially in the medical ICU. We weren't getting any ECMO in the medical ICU. And then with COVID, all of a sudden, the VVs are going there, a couple of sporadic cases. So they're seeing it, they're thinking about it, and they really jumped on board and said, yeah, we're, nurse management, everything. Yeah, we trust you guys to help train us, and we trust the program that's developing, and they're the ones who bear the brunt of this now. They're one-to-one with our ECMO patients, and they get a decent bit of autonomy. I mean, they're not as trained as perfusionists, and neither are we, but you really lean on them to a large degree, much like ECMO specialists. There was an extra corporeal life support organization course, like a 3-day ECMO specialist course, which is kind of the model we adapted our nurse training from. Unfortunately, with COVID, right, no more of those in-person classes, but we really do trust our nursing staff after they've gone through quite a lot of rigorous education, and the perfusionists do too, and we're all, texting each other, and they're just playing a big role in this, but not necessarily sitting there live the entire time.
I think that's what most people don't understand about ECMO, is that someone has to be in the room with them at all times. It's not like a nurse goes in and sets up an IV bag and walks out and comes back an hour later to check on them. Someone is there 100% of the time, even while the patient's sleeping, just to make sure nothing happens. So you can't have someone who might be needed to help a cardiac or cardiothoracic surgeon with a heart surgery. Like a perfusionist needs to run that heart and lung machine in that surgery. He can't sit at the bedside. So it's an interesting approach and I've seen many different hospitals handle it many different ways, but all of them have sort of come back to, who can we train to do this to free up someone who's a little bit more skilled to do what they're actually supposed to be doing. So it's an interesting take on it. If you don't mind, I'd love to shift out of ECMO during COVID, but still talk about ECMO, if that's all right, since that's sort of your specialty. And I would love to talk about, with adoption rates of ECMO sort of soaring, maybe not adoption is not the right term, but with the prevalency of ECMO during COVID, you're going to see innovation coming out of that as more people use it, more people think, well, maybe I could make this better, or maybe we could use ECMO for this. So where do you sort of see ECMO going in the next few years, maybe even decade or so? And what do you think the implications of that will be?
Yeah. So I think, there is a lot of, a lot of development in this field. I think it's clearly growing tremendously, and it's unfortunate that it takes pandemics and wars to kind of give us these steps up, for ECMO support and popularity. But that is the reality, and it's more popular now, more discussed now than ever. I think initially it was very much the purview of cardiovascular surgery and perfusion, and so they're very much of that mindset. And I think venous ECMO from treatment of ARDS and was a natural extension of that. And I think now that's opening up into other natural extensions. And that's one of the benefits of having nurses at bedside is I've got them thinking like nurses, not like perfusionists. And so they're wondering what other things that they see in their typical, other patients, how can we adapt ECMO principles to that versus perfusionists who don't think like that. They don't have that. That's not their job. They're they're specialized in, like you're saying, that bypass devices. So I think indication growth, I'm not call it creep, but growth is something that's we're going to see more and more of as ECMO becomes more and more utilized in other places in medical units. And I think as nurses and other physicians get more comfortable with it, then they start, looking at it as an extension of CRRT, of continuous renal replacement therapy, is something that's viable and not, oh my gosh, we have to go on this crazy device. It's like something we can do. It's something that makes sense, and these concepts hold true. So I'm very excited about the development of some of these lower flow ECMOs or carbon dioxide removal devices. These are things that have flow rates near to dialysis flow rates. That means we can put central lines in that are much smaller than what we use for extracorporeal support. And I think that's one of the main hesitations people have from the medical side, at least, with extracorporeal support is, who's going to put in these rather large catheters that require some specialization? I know my colleague will probably speak about, credentialing and how we're doing that process. But I'm excited to see, hopefully, some continued development in efficiency of gas exchange membranes, and potentially of cannulas and just other means of, if we could start delivering better gas exchange with flow rates of 1 liter per minute, 800 cc's per minute, we're going to open this up to a tremendous amount of opportunities and possibilities. For example, I don't see why in 15 years we should be intubating anybody. There really isn't any reason why we have to be using positive pressure to help lung failure. So, looking back on a polio epidemic and pre-ventilator times, this was all negative pressure, so you're in a tube, a vacuum is generated, diaphragm pulls down, air rushes in. That's how mammals, how all living beings breathe. And before that, we all breathed through extracorporeal support when we were connected to a placenta. So, I imagine, and I hope, and I think we'll be, seeing this develop in the next 5 to 10 years, is the default move of, well, we have to go on ECMO. Well, we have to put a breathing tube in. Well, why? What if we can get these cannulas in pretty quickly, pretty safely? What if we can do this without some of the complications we might see with large bore insertion? Why go to the risk of putting a breathing tube in? Why, so much of the issues we have in critical care, some of the best studies tell us to do less. Don't give high tidal volumes. Don't give too much sedation to your patients. Try to let them be them as much as you can. And a great way of doing that is to not have a piece of plastic in their throat, that we have to put them to sleep for. So I think just that kind of dynamic shift of what do we do with respiratory failure? Why positive pressure? Why not extracorporeal first? And I hope we see more and more of that. We've seen more of that with this, to be honest. I've had a lot of, now transfer requests. Folks are saying, well, what can we transfer to you before we intubate? Part of this, I think, is the relative futility we see in intubating our COVID patients, to where it's like, well, I don't want to do this because I don't think it's going to help this person. So maybe I can get them out to an ECMO center first. We haven't started doing that kind of stuff, but I just think it's expanding the realm of possibility. And the reality is, at some point in some place, it's going to be safer to put someone on ECMO than intubate them.
Yeah. I had never thought of it like the way you put it just now. The negative pressure that all mammals use to breathe. That makes sense. So breathing tubes make sense. I never thought of an ECMO machine acting sort of like a placenta when you were connected to the placenta, pre-birth. That sort of blew my mind just then. And I wanted to call that out because I didn't grow up in the world that you grew up in. So things, you said it so simply and it was so succinctly, but I was over here having my head explode. That made so much sense to me. And also the fact that you can stop someone from having a tube in their throat and being put to sleep, and the negative impacts of that long-term, and normally it's very safe. I'm not saying it's not safe, but if you can do something less invasive, that always beats more invasive, especially when it comes to outcomes and ultimately patient care.
Yeah, without a doubt. And it is safe, but when we're talking about putting a breathing tube in for, a medium to long haul thing like COVID, it's not that safe. The reality is, many of these people don't do well. So I think that's why the question is going to come up is ECMO is not the safest thing either, but we're talking about folks who are very sick and don't have, have a legitimate chance of, unfortunately, mortality and bad outcomes. So in that space, it gives us the opportunity to evaluate what we've been doing and see is something potentially safer, because, mammals breathe with negative pressure. Positive pressure is not something any living being ever saw until the 40s, 50s. That just wasn't a thing. Lungs aren't built to get air pushed into them. It completely distorts kind of the positive negative pressure that our normal, our chests are used to. I'm not suggesting that that's, going to cause some sort of a horrific issue. It's just, it is rather unnatural. And ECMO is more, natural really than that.
Sure. Okay. So I want to take a pause here for a second, because we're at 30 minutes and that's usually how long they go. But I do want to close with one final question, but if you have any other questions or anything information you'd like to get out, I'm happy to ask you a question to sort of elicit that response. So do you have anything that you want to talk about that we haven't yet, or anything like that?
No, I don't think there's anything in particular. I mean, we talked on the emergency medicine part of this. I think there are some other exciting things potentially. I'll just, getting a little mad science over here, but maybe in the later term, once you put someone on ECMO, now you don't need their lungs for for gas exchange, right? So
Sure.
it opens up this huge amount of surface area because you have all these little alveoli, these air sacs, and that's how you breathe. So it's a tremendous amount of surface area. So you can do pretty crazy things like temperature control with it. So, in theory, we could put folks on extracorporeal support and fill their lungs with ice cold barium, ice cold something, and get them to really like suspended animation temperatures, like the stories of kids who fall in a pond, down for hours, but then they wake up, they do okay, is because their body was frozen. It didn't need to use any oxygen. We could do that with these people with some speed. In reality, get to ranges that are almost sci-fi in nature in terms of how cold we can get people. Typically, we'll cool people to 36 degrees Celsius, sometimes 33. This you could get, there's rabbit studies showing, 10 degrees Celsius relatively quickly. So I just think there are whole worlds out there when we kind of separate out the surface area of the lungs from its use in gas exchange and find other things to do with it.
That is wild, and
yeah, right?
I'm looking forward to seeing where that goes in the next. That sounds more like 10, 20, 25 years.
Yeah, probably.
But I mean, there are people who are already in that cryogenic space right now. There are companies already in that space. So I'm sure that they are very much paying attention to this sort of thing as well.
There we go.
So let me close with one final question, if that's all right. And I like to close with this question for our doctors because I feel like a lot of people knew, like you did, I want to be a doctor, and they have no idea really what specialty they want to go into. So if you were talking to someone who was going to go to med school, they had decided on med school, what would be your quote unquote sales pitch for sort of the emergency medical residency, or sort of the career track that you took ultimately?
Yeah. I mean, my pitch for emergency medicine critical care would be that this kind of training really prepares you to be competent and useful in almost any situation where somebody needs something emergently. And you get enough peds for emergency medicine, right? Sometimes we forget that as we get into critical care, but you have peds, you have OB experience, you know at least how to be calm in these situations. You've seen them, you've worked through them. And so in particular, the emergency critical care thing, I think is a great boon from that end. You can deal with not just the ICU parts of your patients. You know how to, deal with some of the, the vaginal bleeding issues, deal with some of the dislocated joints. There's just a lot of things that you're versatile enough to do. And I think in the other perspective, knowing what to do with critically ill people lets you be better at emergency medicine, because you don't always need to, when to get away with, I don't need to do this. Yeah, I know what the book says, but like, I trust myself, this person isn't that sick. I don't need to do X, Y, Z and really go overboard. Versus, people don't have that level of training, that comfort. It's harder to do that. And you feel a little worse, that you weren't, that you have to speak with someone else about this and try to see if you're on the right track with things. So that's my pitch for emergency medicine critical care is, you're able to deal with the sickest of people, but you're able to also deal with their most non-sick and non-acute complaints as well, and really kind of get to know them that way.
It does sound like a very wide range of skill sets. It sort of reminds me of the, jack of all trades of doctors is what it sounds like to me.
Yeah.
Which I think is ultimately very fascinating. You have your hands in a lot of different pots, sort of stirring everything you can, because there's no telling what's going to come through that door in the next 10 minutes, the next 3 days, the next year, right?
Yeah, exactly right. And with the critical care kind of training on top of that, it prepares you to deal with, if stuff can wait, great. If it can't wait, well, then you probably know what to do, because if it can't wait, it probably went to the ICU,
Yeah, excellent. Well, Leon, thank you so much for taking the time to talk with us here on Checking the Vitals. I really, really appreciate it.
My pleasure, Todd. Thanks for having me.
Thank you for listening to Checking the Vitals. If you enjoyed the content we provide, please leave us a 5-star rating and review. It really does help people find the show. And make sure you subscribe so you hear our interviews with healthcare innovators every Monday.